I would like to invite our panelists, Professor Mulyadi, Dr. Ana Ulfa, Dr. Siska, Dr. Budi Rahmat, and Dr. Octaviana to come to the stage. Please, without further ado, let's move to the first agenda, a brief introduction about the Widaya Foundation. Please welcome Mr. Dr. Edianto Widaya to the stage.
Ladies and gentlemen, good afternoon. I am honored to stand before you all today on this remarkable occasion to celebrate the launch of a new initiative that will reshape the landscape of healthcare in Indonesia, the Widaya Foundation. Our tagline is unlocking human potential. Yeah. So the Widaya Foundation is an embodiment of a dream of a healthier Indonesia. It has been crafted out of a profound commitment to the idea that every person deserves the highest quality of medical care, and that this care should be delivered by skilled, competent, and compassionate healthcare professionals. Our mission is ambitious, but our belief is unwavering: to enhance the capability and the competence of our medical practitioners through advanced health learning programs. We aspire to create a healthcare community that is not just educated and proficient, but one that is always eager to learn, to innovate, and to improve. Our foundation recognizes that the rapid pace of change and advancement in the medical field. We see every day how new discoveries, new technology have the potential to transform lives. However, we also understand such progress cannot be truly meaningful unless it reaches every corner of our society. In this spirit, we will focus on areas of medicine that hold immense promise for the future: cardiology, oncology, neurology, genomic therapy, stem cell research, and the last but not least, precision medicine. These represent not just the future of medicine, but the future of humanity. They are the tools through which we can fight the most devastating disease, improve the quality of life, and extend the boundaries of what is medically possible. We aim to create a hub of knowledge and innovation where our medical practitioner will have the opportunity to interact with the global medical professional, participate in cutting-edge research, and gain first-hand experience of the latest medical technology. Through these programs, we hope to bring the frontiers of medical knowledge to our doorstep and empower our practitioners to deliver world-class healthcare services. But the heart of Mandaya Foundation, it is not in our lab or in our classroom. It is in our patient. Our commitment to the people of Indonesia to enhance their lives by ensuring that they receive the best possible healthcare. We seek to create a ripple effect of positive change, where each practitioner will train here will in turn improve the life of 1,000 patients. I'd like to take this opportunity to extend my deepest gratitude to everyone who has made this day possible. To our partners, Royal Brompton and Harefield Hospital UK, thank you so much. Indonesian Pediatric Cardiology Association, thank you so much. And everyone who believes in this dream, your trust and commitment have been invaluable. As we embark on this journey, we invite you to join us, whether you are a medical practitioner, a student, or a policymaker who believe in a healthier Indonesia. We invite you to be part of this transformative journey. We are the Mandaya Foundation, the Widaya Foundation, and we are here to shape healthier future. together will let us revolutionize healthcare in Indonesia, because everyone deserves the best, and we are committed to make it possible. Thank you so much.
Now, before we are moving to the next session, I would like to thank Kalbe Pharma, Interbat, and Dexa Medica who support this event. Our next session will be presented by Dr. Ana Ulfa, who will explain about Tetralogy of Fallot in Indonesia. Let us know more about Dr. Ana herself. She was graduated from Royal Children's Hospital, Melbourne, Australia, specialized in pediatric cardiology, and took subspecialty in pediatric cardiac ICU, also in the same university. Without further ado, please welcome Dr. Ana Ulfa.
Thank you, dear colleague. Good afternoon and good morning for all colleagues in Royal Brompton Hospital, London. First of all, on behalf of the Indonesian Pediatric Cardiology Society, led by Professor Sukman Tulus Putra, I would like to express our sincere gratitude and appreciation to Widaya Foundation, specifically to Mr. Edianto Widaya and Dr. Ben Widaya for organizing this prestigious webinar. About 5 minutes, let me give a presentation of the overview of Tetralogy Fallot in Indonesia. Indonesia is the largest archipelago in the world to form a single state. Consists of 5 main islands and some smaller archipelago, totally about 17,000 islands and islets, in which about 6,000 are inhabited by 275 million population, which is 4 times than UK population. 60% of the population lived in Java and Bali Island. However, despite such huge population, we only have 80 pediatric cardiologists and 17 pediatric cardiac surgeons, and most of them practicing in Java Island, compared to UK, which has 135 pediatric cardiologists and 40 pediatric cardiac surgeons evenly distributed. Indonesia categorized as a low-medium income country, which GDP per capita is about 10% of UK GDP. We are very grateful that this year, 92% of Indonesian population are covered by the National Heart Insurance. Nevertheless, our health budget is very limited. The health expenditure per capita is only $130 compared to UK, which is more than $4,000. Our total fertility rate is 2.1%, which is in every year about 4.4 million babies born in Indonesia, an additional population almost as big as Singaporean total population. With prevalence of 9.3 congenital heart disease per 1,000 live birth, there will be an additional 41,000 congenital heart disease cases per year. As you know, Tetralogy Fallot consists of VSD, right ventricle outflow tract, override of the aorta, and right ventricle hypertrophy. It is the most common cyanotic congenital heart disease that have survived beyond the neonatal period without treatment. Tetralogy Fallot accounting to 5 to 10% of all congenital heart disease. If I use this number, then I come to an estimation of 2,000 babies are born with Tetralogy Fallot every year in Indonesia. Untreated Fallot mortality rate is 50% by the age of 6 years. I tried to collect data from several centers which have the ability to perform Fallot repair, and this is the result. In Jakarta, approximately 300 procedures performed per year, but outside Jakarta, it's not more than 100. In total, there are 400 cases repaired per year. It means only 20% of the additional Fallot cases. Some patients died early, and many are still waiting in the queue for surgery, including those who have prior palliative surgical or non-surgical intervention. The Fallot repair mortality rate varies from 5 to 30% in centers with small load of congenital heart disease surgery. Fallot may contribute to the high infant mortality rate in Indonesia, which is 16.9 versus 2.8 per thousand live births in UK. The total number of Fallot repair is increasing year by year. It was decreasing during COVID pandemic, but last year at the National Cardiovascular Center, almost 200 cases were performed. If we look at this 5-year period data of 832 Fallot repair, only 10% were done in infancy, nearly half at preschool age, and we still have Fallot cases repaired in adulthood. The population of Fallot repair survivors is growing rapidly. It was stated that the 25-year survival rate reached 94%. Nevertheless, the rate of death in the third post-op decade is 3 times higher, and the 40-year survival rate drops to 72%. Some patients may develop late complications such as arrhythmia and heart failure, mainly related to pulmonary regurgitation, which causes right ventricle dysfunction, aortic regurgitation due to aortic root dilatation, which ended with left ventricle dysfunction or other residual lesion. Therefore, all repair Fallot patients should periodically cardiac follow-up. Unfortunately, such standard of care is not consistently practiced in our country. Thank you for what Mandaya Foundation for this great support to our community. Thank you very much. Dear colleague, I will proceed to the main program of this webinar. We are very fortunate to have 2 world-famous experts in the field of pediatric cardiology, Professor Alan Fries and Mr. G. Andreas Hustitsky from Royal Brompton Hospital. Besides these 2 speakers, we also have some panelists. That is Professor Mulyadi MJR, PhD. He is a pediatrician, consultant pediatric cardiologist at Cipto Mangunkusumo Hospital. That's the biggest, the largest tertiary center in Indonesia. He is also practicing at Jakarta Heart Center. He specializes in intervention for congenital heart disease in children. The other 3 panelists are consultants at the National Cardiovascular Center and also practicing at Mandaya Royal Hospital. Dr. Budi Rahmat, he is a prominent pediatric cardiac surgeon who has performed many complex congenital heart disease in children and adults. He will get his PhD within a couple of weeks. for his great job on mitral valve repair in children. And then we have also Dr. Octavia Lidisari. She is a cardiologist, consultant pediatric cardiology. She specializes in imaging congenital heart disease in children and adults, as well as fetal echocardiography. And then the last one is Dr. Siska Syadian. She's a young star. She is a cardiologist, consultant pediatric cardiology. She specializes in interventional for congenital heart disease in children and adults. Without further ado, dear colleagues, I call the first speaker, Professor Alan Fries. He is a consultant of pediatric cardiology who treats both children and adults. He studied medicine and completed his Master of Physiology in Marseille, France. He took his postgraduate training in US at Boston Children's Hospital and Harvard Medical Center. Professor Fries is also Director of Pediatric Cardiology at Royal Brompton Hospital and Harefield Hospital, and is a visiting professor at Imperial College, London. He has a special interest and expertise in interventional catheterization for congenital heart disease, structural heart disease, pulmonary hypertension, and electrophysiology. Professor Fries has published over 140 research papers in this field. Please, Professor Fries, the next 25 minutes is yours.
Thank you very much for the nice introduction. I'm very pleased, we are very pleased, Andreas and myself, to be invited to this event. And we are also grateful for your very nice presentation that better explain us what is the current setting for congenital heart disease and management in Indonesia. So, because we know the audience is mainly many comprises experts in pediatric cardiology, we have decided to focus on more advanced management, and we will not describe the basic features of Tetralogy of Fallot, but more describe the extreme side of the spectrum and how to manage difficult case, including pulmonary atresia. I wish also to state that we have decided with Andreas to do a joint presentation. So if it is okay with you, we will have a single presentation where we will interact with you, between us, with you and the panelists. And please, because we are going to address different areas, from the neonatal and initial management to lifelong assessment of important features like pulmonary regurgitation. Please feel free to break the session and ask questions. And I know we will have also discussion at the end. So we are going to show our slide now. So this is, you see a white screen, right?
Yes.
Which is, so we have, we are going hopefully to transfer the screen to the presentation. We are in Andreas' office, so he's fully responsible of the technology. But as you can see, his technical skills are not only for surgery, but also for this type of situation. So basically, first of all, I have a particular interest with Tetralogy of Fallot because, as several of you knows, Arthur Fallot, was a consultant in my native town, Marseille, and he described first the tetralogy of Fallot with the 4 different components. This has been challenged many years later by Richard Van Prague, who is also one of my mentors in Boston Children's Hospital, who explained that it is the single anomaly. He even called it the monology of Fallot. However, this monology or tetralogy has a lot of variants, and this makes quite complicated its management. So we are going to address the several questions you have answered all together, and there will not be a specific presentation of Mr. Oczyski. And as I have said, we have decided to move, because of the expertise of the audience, toward advanced management, and we will not summarize what is the tetralogy of Fallot, what are the basic characteristics, echocardiography, etc., but we will focus on advanced treatments. So first of all, one of the questions was the ideal type of palliation in tetralogy of Fallot, non-surgical versus surgical. And very clearly, our first intention management is always in the cath lab, always transcatheter intervention, because we know these patients are likely to have at least one open heart surgery and possibly much more than that for complex cases. So we consider ours as a cardiac catheterization as a complement or alternative to surgery. And for initial palliation, we are very much trying to avoid any surgical intervention, especially VT shunt, because we know that when the pulmonary arteries are hypoplastic, this can cause some degree of distortion.
Yes, we will. Yeah, Dr. Budi Rahmat will give some expression of the Indonesian cardiac surgery.
Yeah, nowadays we have a lot of cardiac surgeon that able to do the complete repair. So we begin, usually we have a learning curve. Yeah, some center in the other province outside Jakarta just started the initial tetralogy of Fallot repair. So hopefully their number will be increased, and also their experience also will be increased. Actually, we'll start above 10 kgs plus, yeah. And then if we had our convenience, in our experience, so we will move to a little more babies. I mean, the less than 10 kgs. Nowadays, the mortality rate for the complete repair of tetralogy of Fallot in Indonesia is around, in harapan kita is 3.5%, and in others maybe still 10%.
Okay, so now you have
Yes, it depends on how big is the load of surgery in congenital heart disease. And it's most of the patients who need repair Fallot should have cardiac catheterization. How about in Cipto Mangunkusumo Hospital, Professor Mulyadi?
Yeah, thank you, Dr. Ana. Good afternoon, my colleague. Yes, as introduced by Dr. Ana, yeah, Rumah Sakit Cipto is the second most biggest hospital in Indonesia. We also receive patient with congenital disease, especially for Fallot. Yeah, for Fallot. For example, according to the data during 2022, yeah, there is 75 new Fallot patient, yeah, and 60 patient undergone total repair, and 7 died. So the mortality is around still 10%. I think more slightly higher compared to Harapan Kita Hospital. But we always improve, yeah, our outcome, yeah, by studying, yeah, research and the others. Yeah. So that for the total correction, the mortality is around 10%. Yeah.
10%. Yeah, I think it also in National Cardiovascular Center, the mortality rate is fluctuating between 3.5 to 5%. And lately, Dr. Budi Rahmat and his team is operating in a younger and younger age. But we still have also old patient, adult patient with tetralogy Fallot to be repaired. Is in your center, all cases has to have catheterization prior to the surgery, Prof. Mul, in Cipto Mangunkusumo hospitals. All patients should have catheterization prior to Fallot repair, or you just rely on the AHO study only?
Yeah, but not all of them underwent catheter. But sometimes we depend on the age. Yeah? In the small children, we undergo CT scan.
CT scan.
CT scan. Yeah.
Yes.
CT scan.
Yes, Dr. Vivi is expert in imaging. Do you have an estimation of how many patients, how many percent of the patient had a CT only before surgery? Dr. Vivi, maybe you have an estimation for that.
Yeah, thank you, Dr. Ana, for the questions. Actually, in Harapan Kita Hospital, we starting to perform cardiac CT and cardiac MRI for further examination for tetralogy of Fallot since 2013. And since that, we select the patient of tetralogy of Fallot. Mostly, we send the patient to the cardiac CT examination instead of catheterization. We just perform catheterization in patient with pulmonatresia with suspicion of MAPCAS, and also the tetralogy of Fallot patient with the suspicion of the MAPCAS.
Yes, thank you. I think we can proceed with Professor Alan Fry's presentation. Are you ready, Professor Fry? Hello?
Can you see the slide?
It's nice.
Okay, sorry about that. So I'm going to go back to the title. Yeah, the problem is that now I cannot move. Yeah, hopefully. Yeah, okay. All right, so you can see the title. And as I have said, this title is a joint title. There is my name only here, but Andreas will intervene, so we will do the full presentation together. I hope you can see the slide and you can hear me. And because we believe that this is a panel of experts in the audience as well, we are going to mainly address complex situations, but not remind what is the tetralogy of Fallot and what is the basic management. So very clearly, the first question I'm not going to go through because the answer is simply no, except for pulmonatresia, VSD, MAPCAS. So for out of the complex case, we never do cardiac catheterization pre-surgical repair. But I'm going to show you some example of cardiac catheterization for the second question, which is the ideal type of palliation. So very clearly, the second question about the ideal type of palliation, percutaneous versus surgical, the answer for both of us is that transcatheter intervention is the first intention treatment in all the cases with refractory cyanosis. So we have two types of transcatheter palliation. The first one is right ventricle outflow tract stenting, and the other one is PDA stenting. And because we always discuss with our surgeon, and because these patients are always going to have a subsequent surgical repair after this palliation, we basically reserve PDA stenting to all neonates as first intention treatment. And for this, we always use drug-eluting coronary stent, mainly rather than a bare stent like the Cook formula, because they have a easier profile. They are also, we have found that they are providing a longer term palliation, and they are also softer to accommodate when you have a tortuous right ventricular outflow tract. We always proceed through the aorta because we prefer not to have to cross the intracardiac valve in neonates, because we have, by experience, sometimes have complication like damaging the tricuspid valve. So we go from the femoral artery, but we can also use the carotid artery or the axillary artery is an access route we have more recently used. This is very safe and effective technique for us, and we use it again as first intention is all neonates. When we have PDA that can be opened with prostaglandin, we will prefer always to do PDA stenting instead of right ventricle outflow stent. However, right ventricle outflow stenting is something we will always use when there is no duct. That means if we have, for example, a spelling tetralogy of Fallot, and this is a condition that may sometimes happen, because I have seen on your slide that only 10% of the tetralogy of Fallot can be repaired during the first year of life. So in this situation, we would tend to use RVOT stenting, because obviously after 3-4 weeks, the PDA is closed and it is often impossible to open it with prostaglandin. So RVOT stenting is safe and effective to maintain appropriate oxygen saturation and promote PA branches growth. And this is indicated then in patients without PDA or no possibility to do a PDA stent. So when we have patients who are over 3-4 weeks old, or sometimes who are also too small, when they are less than 2 kilos, it is difficult to get safer arterial access. This technique of RVOT stenting has been pioneered by Oliver Stamper in Birmingham. But this is something we were doing already. I will show you examples that are way before this publication. And here, the important publication for PDA stenting is multi-center UK study from 2017 that demonstrated that PDA stenting has slightly inferior morbid mortality than surgical BT shunt. So this is an example of right ventricular outflow stent, and we are in 2006 in my former hospital in Marseille, and you can see this patient has narrowed right ventricular outflow. At this time I implanted a stent, I think that the vascular stent that is not anymore in the market, and you can see the nice result. And at this time we were really reserving saving the RVOT stenting for, I would say, cases with small pulmonary arteries where the pulmonary artery branches were too small to do PT shunt or to perform complete repair. And then we moved slowly but surely. This case has reasonably developed pulmonary arteries, and this patient had an excellent outcome with surgical repair at 7 months. So this was already something a little bit off-label we were doing in 2006. And now this is a typical example of a more recent case with a 3-kilo newborn with tetralogy of Fallot and severe cyanosis. And then this patient, this baby, is going to have a right ventricular outflow stent. So what you can see here, and this is interesting, is that the stent is quite low. And you can see that there is quite a significant protrusion of the stent. In fact, we try as much as possible not to advance too much the RVOT stenting into the pulmonary artery branch, because we don't want to give too hard time to the surgeon when he's going to repair. In this particular case, I could have probably choose a shorter stent, but what is, I believe, important is to have the stent that doesn't go too far in the pulmonary arteries. Sometimes we cannot avoid that, but when we can, we know it will facilitate the life of our surgeon when he will proceed to surgical repair. And this baby has been discharged 5 years later. Let's move to PDA stenting. This is another newborn, this time with pulmoatresia VSD, ventricular septal defect, so very tortuous PDA. And you can see that the PDA is coming from the aorta. So this is often difficult. Probably a case like today, I will go directly from the axillary artery, where you can put safely a 4 French sheet, and you can advance safely the 4 French sheet through the PDA, and then directly through the 4 French sheet any type of drug-eluting coronary stent. In this particular case, it was a bit technically challenging, but we could advance this from the descending aorta and implant the stent. What is important is in PDA stent, this is a little bit the opposite, because we don't know how far the ductal tissue will extend. Sometimes we have to expand a little bit the stent in the pulmonary artery branches. And sometimes it can be also useful to use this stent to balloon dilate and to stent the pulmonary artery branches in case of left pulmonary coarctation. So in this particular case, the stent went to the right pulmonary artery, but you can see on the CT scan that the distal left pulmonary artery could still nicely grow and develop, and this patient had a successful repair 6 months later. But very likely we need a subsequent intervention on the left pulmonary artery in the future. And this is another case where we have used the carotid approach. So in this particular case, we can directly advance the sheet into the duct, and you can see that there is a tight left pulmonary artery stenosis. So in this particular case, we need to implant the stent toward the left pulmonary artery, and this is what we did to maintain balanced growth of both pulmonary arteries. I think at this stage, Andreas will certainly intervene and optimize the presentation with this slide.
Thank you. I think we will proceed to the second speaker, because it's time up for the second speaker. Mr. Andreas Holsitsky. He's a consultant pediatric cardiac surgeon. He's doing also adult cardiac surgeon, based at Royal Brompton Hospital. He studied medicine at Leiden University in Netherlands and did his postgraduate training in cardiac surgery in London, Bristol, and Manchester. He took congenital cardiac fellowship at Great Ormond Street Hospital and Evelina London Children's Hospital. He has many areas of interest within cardiac surgery. His clinical expertise includes all valve repair surgery, including abstaining anomaly, and repair of complex congenital heart disease in children and adults, aortic root surgery, including valve sparing, aortic root replacement, Ross procedure, and surgery for hypertrophic cardiomyopathy. Please, Andreas. Yes.
Thank you very much for that nice introduction. As we said earlier, we will be swapping between various slideshows just to make it a little bit more of an interactive presentation, as we essentially are partners in the same field. We just complement each other. So thank you very much again for asking me to contribute to your meeting. So I will touch on a few topics here and give you my personal views about palliation, correction, surgical approaches, and then some specific issues. So if we look at the natural history of tetralogy, there's a very nice paper written by Bob Freedom in his book, which is quite telling in showing that most patients remain asymptomatic once they get into contact with specialist doctors. But if you leave tetralogy untreated surgically, only really 10% will survive beyond the age of 20 years. Now, if you look at a relatively evenly distributed healthcare system, like in Western Europe, North America, 90% of those patients who've gone through surgical repair in childhood will be expected to survive at least up until the 5th decade of life. But consequences without surgical correction lead to progressive hypoxemia, hyperplasia of the pulmonary arteries and the right ventricle, development of the collateral circulation from the aorta to the pulmonary circulation, progressive myocardial fibrosis, hypertrophy, and diastolic dysfunction. And because of all of these, on top of the mortality, we choose to correct this condition. And the drive has been over the past few decades to try and do this earlier and earlier. If we look at publications that focus really on what to do with early presentation, I've lifted out those groups and publications that have kind of focused a little bit more on neonatal outcomes for full repairs. Because the question is what do you do if a patient presents immediately in the first few weeks of life with cyanosis or spells? If you look at the Birmingham publication from about a decade ago, you can see that repairs in the neonatal phase, which is about 5% of the overall cohort of patients of a multi-center retrospective study, still have an acceptable mortality compared to an elective later repair. But it certainly is a factor 3 to 4 times at least as big. Similarly, the same experience in other studies, such as Al-Habib and the one from Steiner and his colleagues, all in relatively large number of tetralogy repairs. The other issue that you tend to see, and this is a publication from Christian Pizarro in Namur on the east coast of the US, and James Tainberger, who essentially have demonstrated good outcomes, but risk factors being essentially low birth weight and a small pulmonary artery being a significant risk factor for much more frequent reintervention. And similarly, those who do undergo neonatal surgery not only have a higher mortality, but also have a much higher incidence of transalveolar patch requirements and reintervention. So neonatal repair in very limited centers, relatively good, acceptable mortality, but this is not the mainstay of most centers. What are the benefits of repairing in the first year of life? Now, I think there is much more of a consensus that surgery should really be offered within the first year of life, and most centers would propose to offer surgery between 3 and 9 months of age. We have a tendency to do anything beyond kind of three months and around 5 kilos, up to around 8 to 9 months of age, essentially. What it puts the patient into is an earlier normalization of the cardiovascular physiology with a reduction of secondary damage from the chronic cyanosis. It reduces the harmful effects of chronic hypoxemia. It minimizes the ventricular hypertrophy, and it allows the reverse remodeling. The mortality and morbidity of shunts can be completely eliminated by repairing. And the growth of the pulmonary artery, which becomes capable of providing blood flow and alveolar growth to this developing child, is much better. What we've also seen in our own experience, not just in the experience internationally, is that mortality rates in children who have a definitive early repair in infancy is lower compared to a later repair. And for example, in a big study from Germany some years ago, about a decade ago, showed that mortality rates beyond a year of age are significantly higher than those in the younger age group population. That doesn't negate the fact that many patients still present much later in life, and a decision still needs to be made. What do you do with patients like these? And that's obviously a difficult cohort of patients. We've recently had to again discuss a patient who was unoperated, 33-year-old, very unusual anatomy with totally uncorrected tetralogy, very severe hypertrophy, and incidentally also severe aortic stenosis with a slightly impaired left ventricular function and right ventricular function. So there are many, many issues that come with later on presentation that then start to become more pertinent. So coming back to Alain's initial comment of catheters, are they necessary? In standard tetralogy, in what we tend to see, I completely agree with Professor Frez, but I think in late presentation, I think there is still a place for catheterization. Now, when we look at the ideal palliation for tetralogy, surgical versus non-surgical, I just want to highlight this paper from Birmingham, which essentially shows that they compared their whole cohort, which is about 33% of their tetralogy repairs who've had a palliation, and we're talking about just under 70 patients. Initially mostly shunts versus later on mostly RV outflow tract stenting. They reserved their RV outflow tract stent predominantly for those patients who had severe comorbidities, where it was felt that a shunt would cause hemodynamic issues, for example, gut ischemia from very low blood pressures, diastolic blood pressures, brain pathology issues with steel from cerebral circulation, or those who have a very premature condition. Also, surgical intervention where it was felt that it was very highly likely that the patient would require going on bypass to construct a shunt. Those were selected preferentially for an RV outflow tract stent. Those with very low birth weight, as we know from previous studies, is a risk factor for surgery, and then those who have a duct-dependent pulmonary blood flow early on, or very complex anatomy or hyperplastic pulmonary arteries. And what we can glance from their study is that if you compare shunts to stent, as in RV outflow tract stent, you see a much better oxygenation following the stenting procedure, and also after exchanging from a palliation to a repair, you see a better oxygen level. If you then look at the growth of the pulmonary arteries, and the reason why this was all triggered was learning from the Norwood experience, changing from play-loctatic shunts to the Sarno shunt, the drive towards using much more deoxygenated blood straight from an RV to PA shunt, or in this case, RV outflow tract stent. It's also shown that the LPA and the RPA growth is better compared to a shunt. And you can see that in this right-sided graph. Now, interestingly, this is quite an important paper, which is quite controversial within surgery, in that this compares the Melbourne experience of all surgeons who've practiced within the Melbourne group, who did perform tetralogy repairs. There were 8 surgeons analyzed here, but they selected the 5 surgeons who did 80 cases or more in the study era, which was anywhere from the beginning of the 1980s to the late 2000s, and compared essentially surgical techniques between surgeons and the outcomes in the long run. And essentially this addresses the question, what type of repair do you need to do? How aggressive do you need to be with your incision in the outflow tract? This still essentially comes with roughly the same amount of transannular patches amongst all surgeons, about the classical 2/3 of the tetralogy cohort. But essentially, they were compared small ventriculotomies to larger ventriculotomies, dependent on who the surgeon was. And even though the gradients immediately following tetralogy repair didn't affect the interventions for dilatation, it did certainly influence the re-interventions with surgery for obstruction. I.e., there has to be a balance between a very small transannular patch and a much larger, all the way down to the bottom of the infundibulum. And that's reflected in this graph here, where you can see some surgeons having essentially no intervention for stenosis, red being the line for stenosis, black being no intervention, and green being intervention for essentially valvulation and dilatation. And you can see, green being the line for stenosis, red for valvulation, and black being other and none. So you can see that, for example, this surgeon has a much higher incidence of restenosis due to small ventriculotomies and more residual disease, muscular disease, but essentially no valvulation. So there has to be a balance between leaving a degree of valvular restriction versus making sure that you don't create a very incompetent, lax infundibulum. Now, when you talk about techniques of transannular patches, I think there's a mixture of techniques and not all that much evidence surrounding monocusps, which is, I think, what people use as an alternative to just basic transannular patches. The material doesn't really matter, but when you talk about monocusps being either a Gore-Tex or a monocusp from a valvulus conduit such as a Contegra, the benefits really haven't been shown beyond the operative phase, other than the intensive care stay and the hospital stay being shorter with monocusps compared to just transannular patches. Now, when you talk about what to do with coronary anatomy, it does depend on the size of the annulus, the size of the infundibulum, and I think the mantra that Aldo Castaneda set out in the 1980s about the issue of a LAD, a dominant LAD arising from the right coronary artery, being a contraindication to correct early, I think still stands in the majority of situations. There are various techniques of overcoming this, either by creating a double barrel outflow with a little shunt, or just sufficing with purely an extra anatomical conduit. But growing a child with a palliation initially, and seeing if the infundibulum grows sufficiently subsequent to that to avoid having to put in a conduit may be one of your options if the infundibulum is not significantly hyperplastic. I will stop here and pass back to Professor Fraisse.
I know we are a little bit beyond time, so I'm going to be very quick with second stage of my presentation, and sorry about technical problems. So, yeah, here. Yeah, so I'm going to be very quick. Can you see the presentation?
No.
One moment. We're just going to share it again.
Yeah.
Or maybe from the panelists there is some question to raise. Professor Mulyadi, do you have question or comment on the both presentation?
Okay, thank you, Dr. Anna. Thank you, Professor Alan Fraisse, and Mr. Andreas for your very nice presentation and your experience about population patient with Fallot. I think there are some questions for me to Professor Alan Fraisse. If you face the baby with the severe cyanosis, so what is your consideration to choose RVOT stenting or PD stenting, and which one is the easier for you? Yeah. And the second, if the patient with the vertical duct, what approach do you use? Whether you use the approach from right axial artery or right carotid artery in the vertical duct. And my question to Mr. Andreas is, in the case of total repair after RVT stenting or PD stenting, do you have difficulty to evacuate the stent? And what is your tip to treat the patient after performing RVT stent or PDSN, how to evacuate this stent. Thank you very much, Professor Alain and Mr. Andreas. Thank you very much.
Yes, could you straight answer the question, please?
Yes, so usually we would rather choose PDA stent as first intention treatment. And as you said, it can be sometimes difficult in case of vertical duct. And then between carotid and axillary, for a long time, I have preferred carotid, but we have had several cases, we didn't have any stroke, but we had several cases of thrombosis and subsequently narrowing of one of the carotid artery. And then we've moved more toward axillary approach, which is less risky. We do all our puncture and ultrasound guidance. Then if a PDA stent is not feasible or if we are in a situation where the patient is presenting after 3-4 weeks, then we do our VOT stenting.
As far as the question about the RV outflow tract stent and surgery is concerned, I think it's a very important issue that worries a lot of surgeons. But in fact, what you tend to see on the inside of the heart when you resect this, one depends on how long the stent is, what you do, and how long the stent has been in what you do. So to keep it very simple, if the stent is very, very long and covers the entire length of the infundibulum down into the mid-cavity, what I normally tend to worry about is the support mechanism for the tricuspid valve. And I do leave some little fragments behind if they are in close proximity. You obviously still need to make sure that you divide all the septal, parietal, and parietal muscle bundles out of the infundibulum. But what you tend to see a layer of fibrosis into those septal bands and the parietal bands that you can take out. But generally speaking, what we tend to do is the posterior part of the stent, we do tend to leave significant portions from behind. And that is purely from a safety point of view, just to avoid damaging surrounding structures.
Yes, maybe Dr. Budi want to raise question for your colleague.
Yes, thank you. Dr. Raciski, I just wonder, what do you think about the RVOT stent placement, especially if the stent cross the pulmonary valve? Because we do hope that in later, after the stent placement, maybe 6 months or 1 year or so on, we would like to preserve the pulmonary valve. So I have some patient that already got the stent before. So the valve is attached with the stent. So what do you think? Is it better to put the stent just below the valve, or just put it across the valve? Thank you.
I think in part it depends on really what the size of the annulus is. If you have a reasonably good sized annulus, but you have a spelling tetralogy, and the predominant issue is within the infundibulum, then I think you place the stent within the infundibulum. But if you have a very hyperplastic annulus, you will have to do a decent transannular patch anyway to overcome this gradient at the annular level. So you will have to sacrifice the pulmonary valve, and you will end up with if not severe, if not free, but at least severe pulmonary regurgitation after the surgical procedure anyway. So in that case, I don't mind the stent being across the valve, but you don't want it to poke into the pulmonary artery too much, because the structures, as you know, are fairly thin, and you could potentially cause issues within the surrounding tissues. So I think as long as it crosses the annulus briefly, if you have a very hyperplastic PA, then that's probably okay. What you don't want is this to be in for a year, 2 years, 3 years, i.e. as a long-term palliation, like sometimes some patients would have been. You know, we have obviously the luxury in having a very streamlined service, but I fully appreciate that that's not usual practice in many countries around the world, and the healthcare systems are not geared up to that type of practice everywhere. So I think if you do put an RV outflow tract stent in, you don't want to leave a patient for very long, because it will be very difficult to manage that patient surgically, because it becomes very heavily embedded. It's a bit like a pulmonary artery stent. You would have to cut across that, you know, aggressively, and you know, that makes the operation a little bit more tedious. You know, you will be able to get rid of a lot less of the stent if you leave this longer term. But I think with the size of the stents that are being used, it is not meant to be a long-term palliation anyway.
Mr.
To be honest,
yes.
Sorry, I just wanted to add, to be honest, I can't remember a case. Those cases who need RVOT stenting, they have multi-level obstruction, and I can't remember a case where we thought there was a possibility to do valve-sparing surgery. So we always, on a practical standpoint, put the stent through the infundibulum, but also through the pulmonary valve. So that's on the practical standpoint, that's what's happening.
Yes, Mr. Andreas, if you have a Fallot patient with adequate main pulmonary artery and left pulmonary artery, but hypoplastic right pulmonary artery, which is, let's say, half of the Kirklin tables, will you proceed for early repair, or will you do a BT shunt first?
And at what age is this?
4 years old.
4-year-old.
Yeah.
So, yeah, I mean, Alain is just suggesting we should have a look, but I think in the end of the day, if you have a reasonable sized pulmonary artery, ultimately you are always going to be better off with antegrade flow from a growth point of view, in my view, and maintain the patient cyanosed, uncorrected, but with a palliation, I think over time is not good for the patient. It has so many more side effects. My preference would be to deal with that in a repair, and it's likely that you will need further catheter interventions, that you then go and address that aggressively with catheter dilatations or stenting of that pulmonary artery.
If at the end, at the end of the surgery, the right ventricle pressure is still high, I mean more than 75% of the left ventricle pressure, will you open the pads a little bit and leave a VSD?
Yeah, you can leave a fenestrated patch, a bit analogous to, you know, pulmonary atresia VSD map curve management, but I think it might be illustrated a little bit better in the slides, because Professor Fraisse will show some patients that we've treated who are not dissimilar from what you are describing. So let me just share you the slideshow again. Can you see the slideshow?
Yes.
Okay.
So basically, this is a group of patients with very small pulmonary arteries and MAP CAS. And then the criteria about the size of pulmonary arteries is not enough. And also, we need to have a proactive strategy from birth to make those pulmonary artery grow. So we are talking really about this group of patients, atresia tiny pulmonary arteries and suppression by major aortopulmonary collaterals. I have worked a lot on this, and recently with Andreas, we have achieved very good result with management of those patients after a few years of life. But the first thing to do in those patients, so this strategy is called rehabilitation of the pulmonary arteries and has been pioneered by Boston. But we have also achieved what I believe is most long-term outcome with this group of patients. We published that 10 years ago, and we are still following this pathway. So importantly, first step is initial evaluation. And in this group of patients, yes, we need to do cardiac catheterization because the CT scan will not show very well the tiny native pulmonary arteries and also the origin of the MAPCA. Then the first step is, as Andreas has said, to connect. We need to have antegrade flow, so we need to connect the right ventricle to the pulmonary arteries. And then we do what we call rehabilitation with 2 to 4 transcatheter intervention, followed by occlusion of the MAPCA, because we know that the MAPCAs are often not a reliable source of pulmonary blood flow. However, we obviously occlude only the MAPCAs who are communicating with the native pulmonary arteries. Those who are not communicating, in case of incomplete native pulmonary vasculature, then we need to do unifocalization. And we still need to continue this process after surgical repair. So pulmonary artery rehabilitation continues. So first step, RB2PA connection, early infancy, as soon as possible, usually within the first 3 months of life. Second, interventional catheterization before and after surgical repair. And finally, we proceed with surgical repair when we have a Nakata index over at least 100, preferentially 120, but we also want the patient to have a saturation that is acceptable in the mid-80s and MAPCAs occluded with normal distal PA pressure. If we have a saturation that is too low and a Nakata that is only at 110, 120, we will further dilate, and sometimes we will reoperate the patient to have a larger right ventricular outflow. The study I'm talking about is a retrospective study we did in my previous institution in Marseille that included 20 patients like that. So I'm just going to proceed and show you some examples to see better what we are talking about. So this is a patient with injection into the MAPCA, and you see retrogradely filling of the native pulmonary artery. We call that sometimes a seagull. This was a 1.2 kilo patient, premature patient, and you can see injection through the left MAPCA, opacification of very tiny pulmonary arteries. And you see all the MAPCAs here, but all those MAPCAs are competing with the pulmonary arteries. And in this third patient, so there are 3 different patients. In the third patient, you can see here the native pulmonary arteries. And then we do first transcatheter intervention, and you can see from those tiny central pulmonary arteries, this is the final result with the Nakata at 170 millimeter per square meter. To remind people, the Nakata is the area of the branch PAs indexed to the body surface area. Normal Nakata index is around 250, but we can consider this is suitable over 120, 150 millimeter per square meter. So this patient has from very tiny PAs grows to almost normal PAs and can have a successful surgical repair. And of course, you see all those MAPCAs here, and here on the slide below, they are all occluded, and this is only after that we can proceed with surgical repair. So we've done a lot of stenting. This is a 1.2 kilo baby, and you remember in this case, there was a very tortuous MAPCA from the descending aorta. And what's happening, but because the MAPCA is big, is you see this patient will end up with a much smaller left pulmonary artery. You can see that here than the right pulmonary artery, which we need further intervention. So this is why we try to close MAPCAS as much as possible to decrease this competition. And we have been able to correct all the patients, 100% of them, with no mortality. We did, as Andreas said, some penetrated ASD when we felt the patient was borderline. This is the Nakata index at the time of the repair. We can see that some of them were borderline at around 100. But then this is a case with no native PAs, only MAPCAS. So in this particular case, you have one MAPCA from the left, one MAPCA from the right. Patient is very blue. And then what they did in another center, so this is, they did a central shunt from the aorta. And you can see it doesn't work because often the aorta is a bit dilated, and at every systole, the aorta will compress the shunt. So in this particular case, I had to stent the central shunt, and we also did a right BT shunt to unifocalize the right MAPCA, and eventually this patient could have a complete repair after rehabilitation of those MAPCA and appropriate growth. And the patient's follow-up after repair, we need to further increase the Nakata, further improve the hemodynamic. We consider importantly that a good hemodynamic result is a very complex group of patients, is when you have RV to systemic pressure ratio of less than 0.8, so less than 80% of systemic pressure. And what we have experienced is some of the patients, if we don't continue to do rehabilitation, they may experience right ventricular failure, and 3 of our patients had a late mortality. However, 80% of survival, long-term survival in this group of patients is still good. This is a patient from the Brompton hospital who was not followed when I came in 2014, not followed the usual pathway. He still had MAPCA, so I had to, you see the pulmonary arteries were very small, and then I had to rehabilitate to stent them, and he ultimately still could undergo a surgical repair. This is the development of the right pulmonary artery after balloon dilation, and this is MAPCA before and after all close. So, and just a last extreme example, you can see in this particular case, look at this central pulmonary artery, which is absolutely minuscule. And this is a patient after rehabilitation. We have been able to almost close all the MAPCAs, but the saturation is very low, in the low 70s, and the Nakata is only 97. So we have discussed this case with Andreas, and he's going to operate the patient with almost, with a bit more than 2 years old. But this patient will ultimately have complete repair, hopefully. Yeah, just to say that sometimes we can have patients presenting later in life. We still follow the same pathway. This is a patient that presented at 12-year-old. So you may have some of these patients presenting late in life in Indonesia, but we can still do, importantly, first step, RV2PA conduit, then rehabilitation. And this is a patient from UK who was deemed to be unsuitable in another center, came to see us as second opinion, and you can see the right pulmonary artery where was very, it was a unifocalization, and they were very small, but after rehabilitation they are much bigger, and this was the left pulmonary artery, very difficult technically to reach them. I could put 2 stents, and then the patient could undergo complete repair. There is a YouTube video from the mother acknowledging that without the input of our center, her son was only for palliative treatment and would have been probably dead by now, but he's now 16-year-old. and he is having a very good clinical status.
Yeah, thank you, Professor Price. And then we proceed to case discussion. Dr. Siska, can you prepare for your case? There is some question from the audience online. Is that? Yes, can you show us here? What is the question? Professor Price, from Dr. Nindya Permata from Indonesia. Earlier in your presentation, you stated that point about the echocardiography parameter to assess severe pulmonary regurgitation in right ventricle in Tetralogy Fallot, repair Tetralogy Fallot. Yes. What is your routine echo parameter? Yes. Can you answer the question? This question,
so,
Professor?
Yes, but in fact, this is. I have a couple of slides to answer this question because we don't use echocardiography to decide if pulmonary regurgitation is intervention on the pulmonary regurgitation is necessary or not. We echocardiography, we just follow the patients to assess basic right ventricular function, but our key investigation, which is in the guidelines as well, is cardiac MRI. So I have seen, I think you have cardiac MRI in your center, and this is very important for our patients to assess the pulmonary regurgitation with cardiac MRI. We consider that echocardiography is not reliable enough to decide about pulmonary intervention on pulmonary regurgitation. And to our knowledge, there is no echocardiography guidelines for that. The three main guidelines for replacing a pulmonary valve are first, clinical symptoms. Second, if the patient has any significant arrhythmia. And third, MRI criteria, which I can show on the slide if you wish.
Yes, thank you.
And just to add into that, before I moved to the Brompton years ago, I worked in an environment in the northwest of England where healthcare access had been quite sporadic for quite a lot of poorer parts of the population, and access to MRI was not as good as in more mature settings. Most of those patients did have access to just echocardiography after not having been seen for many, many years. And the mainstay of an initial triage for those patients was pressure half time on the pulmonary valve regurgitation, and generally speaking, it being less than 100 milliseconds was a first indicator to kind of triage the patient if they had been lost to follow-up or had not been under follow-up. But from there on, the patient would be moved to a specialist center into an MRI suite.
Yes, we will continue with the cases from...
Dr. Anna, can I have some
sure.
question? Yes, maybe I will continue the questions regarding the echocardiography examination for pulmonary regurgitation patient. Is there any rule for the 3D echo for replacing cardiac MRI to evaluate the volume and function of right ventricle and left ventricle to decide whether this patient has to be undergo pulmonary valve replacement?
For now, this is not the case. There are interesting studies and paper. However, the 3D echo is mainly for morphology of the right ventricular outflow, not really for functional assessment. So my answer would be no, but I think the 3D echo has his full interest, especially during transcatheter intervention, to help monitoring several some valve replacement to have a good idea of the morphology of the right ventricular outflow. And it also have some potential interest to calculate volume, right ventricular volume in the future. But so far, it has not replaced the MRI, mainly because of the complex shape of the right ventricle. So it's not in the guidelines. And what we are doing in our center, we are doing MRI study mainly after 9-year-old, because it is extremely exceptional that a patient will need a pulmonary valve replacement for pulmonary organization before this age. And the usual time interval between 2 MRI is around 36 months. Patient less than 7-year-old, we often need to do general anesthesia to do MRI. And finally, another criteria for pulmonary valve implantation is when we have dysfunctional outflow with stenosis, and then the criteria is when we have a right ventricular systolic pressure above 2/3 of the systemic pressure. And when we are in this situation, most often we will not only dilate or stent the right ventricular outflow, but also put a valve, because we know that if we dilate and stent the right ventricular outflow, we will create free regurgitation that is often poorly tolerated. So we have for the stenotic RVOT an aggressive approach to implant a valve when the hemodynamic criteria are reached.
Yes. Can we have slides for presentation?
Yes.
Case presentation.
Oh, okay.
Dr. Siska, can you
Thank
start?
Yes, Dr.
Can we
Anna,
start?
thank you so much. Thank you, Dr. Anna, for the opportunity, and good evening, everyone. Thank you for joining us today, and thank you, Prof. Allen and Mr. Andreas, for the time. We really enjoyed all your sharing knowledge, and we hope we can learn much from you through our cases today. We have 2 cases here. So the first one is actually Tetralogy Fallot with heart failure due to left ventricular dysfunction. Heart failure due to left ventricular dysfunction is actually a very, very rare complication, and it can increase morbidity and mortality risk, especially related to the surgical correction. And we need to think about the alternative intervention, and we have palliative intervention as bridging therapy here, BTD shunt or transcatheter intervention. And now there's PDA stenting or RVT stenting, just like you explained before, become our choices. And this is the first case, the boy, 7 years old, that came with shortness of breath, and he also complained of dyspnea on exertion, waking up during sleep, orthopnea and cyanosis as well. And the patient experienced recurrent spell also, and actually been diagnosed with Tetralogy of Fallot since 2019, but lost to follow-up due to pandemic. Then the physical examination showed the saturation of oxygen is really low. It's about 68%, and we may see here the pressure of the jugular vein is increased, and from heart we may see that ejection systolic murmur, and then the hepatomegaly on abdomen, and the extremity showed edema on the extremities with cupping fingers. And from ECG we may appreciate right axis deviation with enlargement of the right atrium and hypertrophy of the right ventricle. We may also see the very large heart here with CTR about 68%, concave pulmonary segment, and we may see oligemic on the pulmonal. And then from echocardiography we can appreciate from the long axis view here very big VSD, right to left shunt with overriding aorta about 50% and mild AR. And then we may see also the ejection fraction is not really good, it's about 40% with global LV hypokinetic. And then we may see the LV thrombus with the size about 9 times 12 millimeter here. Then from the short axis, we may confirm the diagnosis of tetralogy of Fallot with VSD, with right ventricular hypertrophy, with overriding of the aorta and septum deviation here with pulmonary stenosis. It is severe pulmonary stenosis with confluent PA, but the size is actually really small. It's about 6 to 7 millimeters, and when we measure the Mcgun ratio, it's only 1.4, and the RVPA pressure is actually very high, 96 millimeter mercury. From laboratory test, we may see the increase of hemoglobin and hematocrit, and the blood gas analysis showed the pressure and the saturation of the oxygen is actually low, and the lactic acid is about 1.9. So the patient diagnosed with tetralogy of Fallot, heart failure, and then we have found thrombus and confluent PL with very small size of the PA. The patient then got diuretic, beta blocker, and ACE inhibitor, and then we admitted him to the ward, but actually he always experienced hypercyanotic spell, and we managed with niches position, adequate oxygenation, rehydration, diazepam, morphine, and give everything, but the condition is actually not improving yet, and the patient fell into cardiac arrest repeatedly, and then we did CPR. Then the patient we sent to ICU with inotropic mechanical ventilation, but the saturation is still low. So we actually face a case with tetralogy of Fallot, but it's not a simple tetralogy of Fallot. It's a tetralogy of Fallot with LV dysfunction, with hypercyanotic spell, and with recurrent cardiac arrest. So what is your suggestion? We will discuss this, and I will give the time to Dr. Anna as well to lead the discussion with our panelists and our speakers. Thank you, Dr. Anna.
Yes, I would like to have comment from Prof. Freich and Mr. Andreas. What do you prefer to manage this patient? Professor.
So if Andreas wants to operate this patient, I would be very happy, but I don't think it is going to happen, unfortunately, because what we are seeing here is, I would say, end-stage consequence of chronic cyanosis and also RVOT obstruction. So I think, unfortunately, there is not too much to do. The outcome of this patient is very poor. The prognosis of this patient is very poor. And I think probably at this stage, I will go to the cath lab to better assess the morphology of the pulmonary artery vasculature, check whether or not there are some markers, and I also want to have the hemodynamic, because as there is a left ventricular dysfunction, which by the way can happen even after repaired tetralogy of Fallot in up to 25% of the case because of the interventricular interactions, because of multiple parameters. So in this particular case, I would clearly go to the cath lab to assess the situation and to see whether or not this patient has normal or elevated pulmonary artery pressure, because I suspect part of the worsening condition might be because the left ventricle is so impaired that it can create, it can increase the pulmonary vascular resistance, and this is why this is a vicious circle, because the left ventricle is worsening because of the chronic cyanosis, and then it is decreasing the pulmonary blood flow because of post-capillary elevated pressure. So based on the CAT, if I think is suitable, if there is any potential improvement with balloon dilation of the of some of the pulmonary artery or even stenting, I will do that. I will try as much as possible to preserve the valve function of the right ventricular outflow, but I will see with whether or not there is the need also to valvulate, because the goal, the first aim in this patient is to try to improve the cyanosis. If the cyanosis is less than 70%, the risk of cardiac arrest, subsequent death is extremely high.
Yes.
So that would be my immediate management. I would probably try some vasodilators or pulmonary vasodilator like sildenafil in PICU to see if we can improve a little bit the solution. But if the patient is suitable, I will go to the cath lab. Is that?
Yeah, I mean, from a surgical point of view, I have, quite grave concerns about operating on a patient like this with significant LV dysfunction, either by palliation or full repair. I think palliation is, from a surgical point of view, not really an option here, because even if you put in a small shunt, it might not be sufficient to increase the pulmonary blood flows enough, and you wouldn't want to do that until you confirm that the PVR is decent enough. You might load the ventricle more. There's lots of downsides to that. On top of that, it just kind of illustrates that chronic cyanosis causes so many side effects that essentially promote this more rapid decline of biventricular function. I think you have to be, if you ever get to an operation, you have to be prepared that you have a very, very stormy post-operative phase. I've operated on quite a few late presentation tetralogies in teenage years or in kind of similar age group as this. Like I said, we are now discussing a patient who has been accepted for transplantation, might not make it to actually getting an organ, and if he does deteriorate as an inpatient, we might be forced to do a very high risk operation. There are still many patients like that coming through, and they are extremely challenging. But I think the predominant issue with these patients that you will tend to see is, one, the LV is just not used to doing the work from a hyperoxygenated phase, and two is the right ventricle is too stiff, so you get right ventricular failure, and that's often the mode of either death or prolonged ICU stay. It is very difficult to manage right ventricular failure with a very, very tight Starling curve. So I think my view would be, if there is any option for this child at this stage, I think the option should be, if the anatomy of the RV outflow tract is such that it's technically feasible, either to suffice with a balloon to the valve if it's predominantly a valve problem, but it very rarely is, but to do a combination of cath manipulation, either by means of an RV outflow tract stent, as hopefully I've demonstrated in my slides earlier, which is probably better than putting in a shunt, with or without a pulmonary valvuloplasty at the same time. And if the child improves with improved oxygenation after relatively frequent assessment, I think doing an operation at 7 or at 8 years or at 8.5 years, I don't think is going to make a huge impact on the prognosis of this child. What you want is to make the oxygenation more stable, and if that improves ventricular function, that would be great. If it doesn't improve ventricular function, then you then have to make a decision. Are you going to offer a very high risk mortality repair, or are you going to accept that this might be the end stage of surgical treatment?
Yes. Professor Mulyadi, if you have such case in Ciptomangunkusumo, what are you going to do?
Yeah, thank you for Dr. Siska. in Cipto, actually, I didn't have much experience about RVOT stenting. I still doing BT-SAM, yeah. But some colleague in other hospital has doing, yeah. But I didn't have. At the time, we also have like case. I sent to the surgeon to do BT-SAM, yeah, at the time. But unfortunately, the patient lost of follow-up, but I do not know about the outcome. Yeah. Maybe Dr. Ruby, yeah, will add, yeah, because the patient, maybe the patient go to Dr. Ruby, maybe.
Dr. Ruby is another pediatric cardiologist in Cipto Mangunkusumo Hospital. And Dr. Radit also, I would like to have your comment. Yes, Dr.
Thank you,
Ruby,
Dr. Anna.
yes.
Maybe I will give my our experience in our unit regarding the tetralogy valve with LV dysfunction. In these cases that we met, usually we do the BT-SAM first. Although the PA size is quite good for total correction, but because of the unsuitable LV dysfunction, usually we do 2 steps before we do the correction. Thank you.
Yes, there is Dr. Radityo. What is your comment in such case? What do you propose?
Yeah, thank you very much, Dr. Anna. In this case, I prefer to do non-surgical intervention since the complexity can be reduced, and also we can add some pulmonary blood flow without any CPB. So I prefer to use RVOT stenting.
Yes.
Thank you.
You can continue.
Thank you, Dr. Anna. And I will proceed to the next slide. Thank you, Prof. Allen and Dr. Andres for some suggestion. And Prof. Allen, we actually follow your suggestion. So we transfer the patient to the cath lab. And this is the RVOT angiography that showed pulmonary stenosis is very severe. And then we try at that moment to do the RVOT stenting. So Dr. Adityo, who just talked a few minutes ago, he's the one that do the procedure. So this is the procedure during the balloon dilatation. Is
sorry,
first,
we can't see the slide.
Oh, sorry, slide-nya nggak jalan. Yes, Prof.
Slide, please.
We try to proceed. I actually have proceed the next step of slide. Okay, this is the one when the stiff wire goes to the right pulmonary artery, and then the balloon dilate, and then the stent we try to implant, but recurrent cardiac arrest happen, and then actually CPR also continued. Then this is the last one. The stent is actually implanted here, and then we may see the flow from the RV to the branches of the pulmonary artery is good, and we may see also the pressure gradient is actually decreased to 28, and the saturation of the patient increased from 64 to 92%. Then this is the condition of the patient at day 8 post procedure. We may appreciate the LV function is good now, and then we may see the stent also stood in place in short axis, and from the last slide we can see the PV flow is adequate. Then we want to compare the condition before and after the procedure. You may see here that the ventricular function is actually improving. That's the first case, Dr. Anna. Thank you.
Thank you, Dr. Siska. I think we ran out of time, so we could not continue with the second case. Thank you very much. Dear colleagues, it is clear that in this modern area, it's recommended that tetralogy Fallot patient should undergo repair early. And in developed countries, they do it in infancy. It's a challenge for Dr. Budi, yeah? Since older age was reported to be associated with a higher rate of in-hospital complication related to the higher incidence of end-diastolic forward flow, which might be attributed to the stiffer right ventricle and higher diastolic dysfunction, as well as systolic dysfunction due to prolonged cyanosis. The transarterial or transventricular approach are effective. However, the smallest possible ventriculotomy should be utilized. When possible, the pulmonary valve should be spared. And if unsalvageable, then reconstruction can be considered. At the conclusion of the operation, adequate relief of the right ventricle outflow tract should be confirmed, and identification of a significant fixed anatomic obstruction should promptly further intervention. The management of Tetralogy Fallot has improved greatly, and patient may now expect a near normal life expectancy. This success, however, has been coupled with increasing observation of late complication, including arrhythmia, pulmonary regurgitation, and sudden cardiac death. Therefore, long-term follow-up is mandatory for each patient who has Fallot repair. Professor Freis and Mr. Andreas, thank you for sharing your broad experience with us. Thank you also to the panelists who have made this discussion lively. I hope this webinar will be improved our understanding to be able to provide the high profession of care required for Fallot patients in Indonesia. There are so many challenges we face in dealing with congenital heart disease in our country. We should work together hand in hand to save children's lives with congenital heart disease. To all the audience, thank you so much for your participation in this webinar. And last but not least, thank you to Widaya Foundation, Mandaya Royal Hospital Management, especially Dr. Essie and her team, Calwe Pharma, Dexa Medica, and Interbat for making this webinar a great success. Thank you and good evening.